Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. Every year, about 150,000 Americans are diagnosed with epilepsy, a central nervous system disorder that causes seizures. With treatment, about 70% of people with epilepsy can go into remission. There's been a lot of progress in epilepsy testing and surgical treatments. Many more are minimally invasive and more effective. We'll be talking about these state-of-the-art treatments that do more through less with Dr. Peter Konrad, Chair of the Department of Neurosurgery at the WVU Rockefeller Neuroscience Institute. Welcome, Dr. Konrad, to Tuesday Talks.
Thank you, Mary. Pleasure to
Bumpy
be here.
Start there, but we're okay.
Yes.
Now, we encourage you to post any epilepsy questions you may have in the comments section below, and we'll try to answer them live. Okay, so let's start first with just talking about the WVU Rockefeller Neuroscience Institute. I mean, you guys are always doing something interesting over there. There's a lot of expertise and experience over there, isn't there?
Yes, very, very much so. It's a unique center in the United States, and our expertise is comprehensive, meaning we cover all aspects of neuroscience care and management and therapy and diagnosis. So epilepsy is a very common disorder, like you had said. In fact, if you know 100 people, you know someone with epilepsy. It's 1% of the population of the United States has epilepsy, and that's true around the world. So it's a common thing, and a center like the Rockefeller Neuroscience Institute has experts in all aspects of treating that. So we're a comprehensive epilepsy treatment center. That means we have surgeons. We have 3 full-time neurosurgeons on staff available to treat different aspects to that, plus 2 pediatric neurosurgeons also involved in that care. We have 4 or 5 epilepsy neurology specialists who are good at understanding the medical and diagnostic treatment. We have a team of experts to help find seizures in the brain and where they're occurring electrically and how they look on scans. And that's really what goes into a comprehensive epilepsy treatment program.
Now, there are different ways to treat epilepsy, and I'm going to assume that you usually start with medications and then, work your way, if necessary, up to surgery.
Exactly. In general, in medicine, we always weigh risk-benefit. So for the most part, in epilepsy, it's true that the first line of treatment, actually the first line is understanding what's causing the epilepsy. So diagnosis is what we need to establish first. But assuming we know somebody has epilepsy, which is really recurrent seizure. So just to get it straight, a seizure is a one-time incident. But if you have multiple seizures, you then have a disease called epilepsy. Okay, and so upon knowing somebody has epilepsy with recurrent seizures, then obviously the first attempt is to give them medicines, and for the most part that works pretty well for a majority of people. But a certain percentage of those people, 30 to 40%, wind up requiring additional medications. And we know from decades worth of work in this area as a community as a whole that after people fail their second medical treatment, they've tried 2 anti-epileptic medications, it's unlikely that additional medicines are likely to fix their seizures. So at that point, these medicines are not benign, as most people know or have been exposed to it. They're very potent medications, and some of them can be quite toxic. So we want to be sure we don't have people on medicines that are ineffective and potentially harmful. And that usually then leads to the question like, where's the seizure coming from? Is there a way to maybe help that sick part of the brain out in methods of using surgery or implants, as we'll talk about?
Okay. All right. Now, these procedures, the surgical procedures that we're going to be talking about, they're becoming less invasive, more effective, and we're going to talk about a few of the latest treatments because there's really been some significant advances. All right, and I'm just saying this to impress everybody. We're going to first talk about amygdala hippocampectomy. All right, I was close. What exactly is this? You said it's also called selective resection. What exactly is this, and What type of epilepsy patients is this procedure for?
So in general, this is a very common type of surgery to perform for people with an epilepsy that occurs in the temporal lobe, which is right in front of the ears. It's near your temples.
Okay.
And it's, in general, represents the most successful surgery type of patient. When you have seizures occurring in this part of the brain, we know that a significant percentage of people with those seizures in that part of the brain usually wind up failing medications. They quickly go on to 2, 3, 4 medicines, and the seizures still persist. And of course, we know persistent seizures is unhealthy for the brain because it's like your computer having to work through a bad circuit. It's constantly resetting your brain, your awareness changes, people have loss of attention, and if they're driving, for instance, that can be dangerous. There's a condition that was actually just on a recent TV spot on SUDEP, which is sudden death due to epilepsy, and it happens at night in children who have seizures and happen to be perhaps laying in a bad position, and they can actually die from this. And so there's a lot of interest in pursuing, how to treat this when medications don't fail. So the standard surgery we tend to perform is one in which we get rid of a sick part of the brain, and it's usually about the size of the end of your thumb or a small almond, and it's called the hippocampus, and another structure with it, the amygdala. So when we take that little area out, we call that a selective amygdalohippocampectomy. We take out one little part. And I tell patients a lot, it's like having a bad kidney and a good kidney. You have two kidneys. We know that we can take a sick area of the brain out as long as the other side of the brain's working well.
Yeah.
And so the goal, obviously, in a good center and a good team is to find that area that's not healthy with the seizures, and then we go for it. Now, what's changed a lot in the last 20 years is that it used to be a pretty big surgery. People spent upwards of a week in the hospital, maybe multiple surgeries, and that surgery has changed a lot.
Yeah, I mean, well, first of all, we were talking about this before the show. I didn't realize that most epilepsy surgeries, you're taking out a part of the brain. But you said it's usually an unhealthy part of the brain.
Correct.
Like, I didn't know you could be without part of the hippocampus.
Yes. Well, if you ask what does the hippocampus do, it's involved in memory. And if you know anybody who has epilepsy, their memory gets affected very early on because typically the hippocampus is involved. And why is their memory failing? It's because one side of the brain is having bad electrical activity due to the seizures, and it's actually interrupting the healthy part of the brain. So it is useful to take out bad parts that are not working well, just like a tumor. Obviously, if you had a tumor in your brain and it's involving part of the brain, that's an unhealthy part of the brain.
Right.
So our goal in this surgery is to be certain that we know where that unhealthy spot is, and this is why the comprehensive team is very good at sleuthing that out and figuring out where that's at. And then we develop as a team a strategy in which we have confidence that if we remove that area, it's going to fix the seizures, and confidence that if we remove that area, it doesn't actually result in a problem. And we go through standard tests to determine that, and we have very exact statistics on it. So this procedure, as I said in the past, used to be very involved and scary for many people because the surgery was much more extensive, much like total hip surgery used to be a huge deal a number of years ago.
Yeah.
But if you know anything about total hips and how much has it come along in the orthopedic world, these are now very minimally oriented procedures. And so today we want to talk about sort of how these epilepsy surgeries have actually done the same thing. They've become very minimal. So
Yeah, you said that it used to involve a long hospital stay. So now when you do a selective resection, how long is usually the hospital stay?
Usually it's, my patients usually leave in about 2 days, and the surgery site is much smaller. We have one slide where we kind of reviewed a paper that my colleagues and I, when I was at Vanderbilt, we looked at about 18 years of our experience with this minimally invasive form of epilepsy surgery called a selective amygdalohippocampectomy, and just published that. This was on 211 patients who myself and others of our team had operated on over 18 years. And the diagram shows kind of the small incision in front of the ear. It used to be an entire side of the head that we'd have to expose and get open and make sure we were approaching it correctly. But now through guidance using navigational systems, robotics, higher level of technology, we can reduce this to a very precise surgery, much like everything else in surgery and medicine. We just take out this little structure through a very small corridor. And most of that is done in a morning for the patient.
So did you find through this study that this is basically safe and effective?
Yes. So we compared it with the standard approaches, which we will call an ATL or an anterior temporal lobe. That was the old way to do it, and obviously we want to compare our results. We actually found, so as I showed on the slide here, 73% of patients actually had what's called an Angle 1 outcome, which means at 2 years they had no seizures or no evidence of external seizures. And then if you look at how many patients just had one seizure, which is an Angle 2, that was another 16%. So with this surgery, we get an outcome that's around 90% effective in eliminating or having one seizure a year in people who were probably having several a week. That's life transforming for somebody.
Definitely.
And it compared not only favorably, but actually better for complication rates. I drew a little red arrow or a circle around the selective resection cases versus the ATLs. And in every instance, you'll see that, and this was a large review of the literature plus our own experience. In all cases, the complications were much less. As you would expect, less approach, smaller, more focused, targeted, solution. People are going to do better, they're home sooner, and they're not nearly as encumbered. Most people would return to work or have, back to their normal baseline within a few weeks after the surgery.
Wow. That's come a long way.
So it's come an astronomical distance from where it was when I was in training 25 years ago.
Wow. Interesting. Okay, now we have some other minimally invasive procedures to talk about here. The next one is interstitial thermal therapy, or LIT.
Yes.
Now, what is this and who's it for?
Okay, so LIT is another way to accomplish destruction or removal of a bad circuit in the brain through a little laser probe. And on this slide, there's a couple of companies that make these devices. We happen to use one from a company called Medtronic. It's called the Visualize system, but essentially the concept's all the same. You insert a little laser probe through a teeny hole about the size of 1/8 of an inch or so.
Oh, wow.
And there's a little puncture in the scalp, and we put that little probe through a guide, typically a robotic guide or a system we use to guide the insertion. And if we know the seizure focus well enough, we can stick the laser in there and basically create a little hole or knock that area out. So it's very, very non-invasive. People usually go home within 24 hours from that. There's minimal recovery from it. It's all done inside the MRI scanner with people asleep. And so it's a really good technique that we've been doing here at WVU for a number of years. LIT's been out for probably about 5-10 years. And the team here is experienced at doing that too.
Wow.
The difference is if you just look at the outcomes, LIT therapy has about a 60 to 70% likelihood of seizure reduction compared to a selective procedure, which might have 80 to 90% if the appropriate patients are selected. But you can go many different places with the LIT therapy in the brain that the selective procedure doesn't address. So it gives us more tools to approach tougher areas in the brain that might be too risky to do a big open surgery on. Wow. So we discuss a lot of these options when we learn about the patient's seizures.
Wow, and I saw it had on the slide there, you can go home in 24 hours.
Yes, ma'am.
That's practically outpatient.
That
Not
is
quite, but it's close.
Outpatient, exactly.
And that's where you want to work toward, right?
Yes.
That's what we're working toward. Okay. Let's talk about responsive neurostimulation, or RNS. Now, from when I read about this, they compare it to that it's similar to a heart pacemaker, but it's for the brain.
Exactly.
Okay.
So responsive neurostimulation is in a category what we call neuromodulation. So this is a little different approach to taking care of seizures. Cutting a piece of the brain out or burning a little hole in the circuit with a laser, those are ablative or resective things. So we knock out the bad circuit because we know we can do that safely and it's effective. But there are obviously other areas of the brain, as you raised the concern about. You didn't know you could take out certain areas of the brain. Well, we can't do that for everywhere. Speech areas, for instance, or areas that control vision or feeling or movement, those areas we can't take out. So if you have seizures in those areas, what else could you do other than take more medicines? And we already know that at a certain point those medicines aren't effective. So we have what's called neuromodulation. These are non-destructive implants that basically adjust the electrical activity through a little internal electronic device. So again, it's all about knowing where that electrical activity is abnormal. The RNS system was approved about 10 years ago. It was a very brand new, totally different way of putting a device in contact with the brain because it has, as the name says, a responsive stimulation. It measures the electrical activity in the brain from these little probes we put in, and then the computer inside of it detects the seizure and then basically delivers a stimulation therapy to contain the seizure. So instead of getting rid of the bad circuit, it's like fencing the bad stuff in a small area. So basically by putting the electrode around the seizure focus, we tend to contain it. And that data has been looked at now for about 10 years, and it's very encouraging. Every year, those people tend to have fewer and fewer seizures.
Wow.
So this is a very good alternative. And in addition to the RNS, that's kind of the fancy new shiny object in the world of epilepsy neuromodulation. But we also have vagus nerve stimulation, which is another way to adjust seizures, and deep brain stimulation, which is a different approach, but same concept. These are electrical tools that allow us to adjust seizures in the brain.
And we're not only using those to treat epilepsy. We're at RNI, we're using them to treat addiction and all kinds of things.
The original,
disorders.
for deep brain stimulation, this has been around for about 24 years as an FDA-approved tool for Parkinson's and for tremors. And it just recently got approved for epilepsy, about 3 to 5 years ago. So it's an expanded tool. But about 350,000 people have deep brain stimulators in them, mostly for Parkinson's and tremor.
Right.
So epilepsy is the new kid on the block for DBS.
But it's effective for epilepsy too. That's great. I mean, again, life-changing procedures. Okay, now we're going to talk about ROSA, which is robotic guided procedures for precision placement of lasers or electrodes. And now we talked about the last procedure being like a pacemaker, but ROSA is like a GPS device for your brain.
ROSA is a new tool for a lot of surgeons. Again, ROSA entered the market for brain surgery as a robot tool, mostly to start out in epilepsy, actually. Because in hunting down the source of seizures, the old way was we'd make a window in the skull and we would put a layer of electrodes over the surface of the brain.
Wow.
But the seizures were traveling all inside the brain throughout it. So what's replaced that now, which is much less invasive, is very precise electrodes we put into the circuit areas we know are conducting the seizures, like the highways. And we're studying where those seizures travel on those highways. To precisely put those around, we don't just do that by hand. We use the scan, the MRI, and we couple it with a robot or some other precision tool. We have several of these different versions, and we use that to insert these micro wires into the brain through little punctures, and that's called a stereo EEG. Those electrodes are called stereo EEGs, and the ROSA is the tool that actually lets us do that quickly. The old way that was done about 15 years ago in Europe, they had a large frame. It would take almost a whole day to put 10 of those in. Now we can use the ROSA robot to insert 15 or 20 micro wires through the brain in easily a few hours in the morning.
Does a patient have to be having a seizure for you, when you're looking for you to find where these seizures are starting from?
That's a really good question. So typically, when we do these mapping procedures or things where we hunt the seizures down, we actually bring the patient into the hospital for about a week or up to 3 weeks. And that's true for any major epilepsy center. So what I'm saying here is just sort of standard of how it's done
Sure.
elsewhere also. But we bring them in the hospital, and typically we reduce their seizure medicines to allow them to have small seizures. We don't want them to have big seizures, but we just want to watch how that seizure is traveling through the brain. And those little electrodes basically are like little traffic cops everywhere that are spotting the speeders on the highway. And they report to us electrically kind of, okay, this is where it's coming from. And it takes a lot of experts to do this. The neurologists, they have a special area called epileptology, and that's just a neurologist whose sole purpose is just understanding seizure management.
Wow.
We have 5 of those here at WVU, both in adult and pediatrics. And then there's special equipment in the hospital that the hospital's invested to basically do this service for our patients. And we have 6 beds dedicated in our neuroscience area for seizure monitoring. So
Wow.
we probably monitor at least, I would say probably 30 to 40 patients a month for
Wow.
seizures. So
Wow.
it's, again, 1% of the population has epilepsy. If you just think about the ones that don't respond to medicines, you can see why, there's a fairly active role for us here to do this.
Yeah. You can't fix it till you know where it's
Yep,
coming from, right?
exactly.
Yeah.
So that little bit of traffic monitoring is exactly right. So we actually look for the seizures, and that's how we arrive at an understanding of where the source is.
Okay. All right. Now, you did just touch on before about, you mentioned stereotactic EEG?
Yeah, stereo EEG.
Okay, stereo EEG. But you also mentioned here there was stereotactic EEG electrodes, which is basically a process that helps capture a 3-dimensional
Yes.
understanding of seizures. How the heck does that work?
Yes. So again, it's gotten very technical. We're benefiting from a lot of, today, a lot of computer technology that's evolved over a number of years, robotic technology. This is what's led us to be much less invasive. And then most people probably are familiar with AI, artificial intelligence-driven things. If you just search on anything in Google, for instance, you don't just get anything back. There's a system, an AI process, where there's an artificially software program that actually prunes what you're looking at. So it turns out today, the last several years, we've seen a lot of these high-tech computer science AI-driven analysis. So we literally, once we have, you can imagine, 15 electrodes in the brain at very precise points,
Right.
we have a complete 3-dimensional view of the brain from the MRI scan. We take that data and import it into a special software program that lets us 3-dimensionally see how that traffic is going through the brain and find the source of where the seizures are coming from. That technology is not available everywhere, but we have a
We have
very
it here.
good opportunity to use that here.
Wow. There's an app for that, huh?
There's an app for that.
Wow. Very precise. And I did want to talk a little bit more about deep brain stimulation. Because basically, the WVU Rockefeller Neuroscience Institute has been leading the way in this technology to treat many different conditions. And I know you talked about how we're using it for epilepsy, but can you expand on that a little?
Sure. I came here about 2 years ago, and I had been at Vanderbilt for about 22 years practicing there, and I came here specifically because of the Institute's recruitment of experts in this area. I had been doing deep brain stimulation a lot for Parkinson's and now more recently for epilepsy, and Dr. Rezai, the Institute director, and I had known each other professionally for 20-some years, and this was a great opportunity to come here. And so the backdrop to that statement is that between the two of us, we'd been doing DBS, 20 plus years each. We have probably one of the 50 years experience just between the two of us, plus Dr. Brandmere is also one of our neurosurgeons who's an expert in this, and he's been with us for a number of years. So in general, deep brain stimulation is a very, we have a deep bench in that, surgically speaking and neurologically speaking. We have a whole separate team of neurologists that deal with Parkinson's patients, for instance, versus the epilepsy group. Totally different group, but as surgeons, we deal with groups of people who are really good at helping us hone in on where problems occur at. And once we know where something's at, as a surgeon, then we can actually have a lot more tools today than we ever did before to affect it. For Parkinson's, we know that circuit's very small, and DBS has been shown very effective for treating Parkinson's in a number of symptoms related for that. It's no surprise that DBS could be used for epilepsy because the moment we know where the gateways of those seizures are coming through, if we can't take the source out, we can at least put a roadblock in the process of where the seizure spread is. And that's how DBS helps us for epilepsy. We know that it travels through a region called the thalamus, the anterior thalamus. And so when you put a roadblock there, the seizures erupt, but they don't get very far. So the patient doesn't have a big seizure, they have a teeny one usually, or maybe just an awareness change. And that, again, changes it from a much more risky thing where you're having convulsions that are much more dangerous and bad for the brain and the rest of the body, to something that's much less. Ideally, we want nobody to have any seizures, but sometimes where it is in the brain just doesn't let us, today at least, take it out, or medicines aren't effective. But, perhaps in the near future, we can use things like gene therapy or our focused ultrasound system, which is very good at opening parts of the brain, and we're looking forward to understanding more about perhaps how focused ultrasound could even help with seizures.
A lot of hope out there for epilepsy patients.
Yes.
Okay.
This is a good time to be thinking about getting epilepsy worked up because a lot has changed.
Wow.
It used to be very scary for most people, and they would stay with the medicine for much longer than it was actually helping. But nowadays, that fear doesn't have to be there because we have a lot better things for them.
That's great. So just before we wrap up, for people that are watching this, what's the most important thing you want them to know about these state-of-the-art, minimally invasive treatments and how epilepsy treatment is evolving?
Yeah, I think there's a couple messages for sure. And one is not to be scared about surgery as an option because it's very different now than it even was 5 years ago. So if you've not talked to somebody about your seizures in 5 years, you haven't heard what's available nowadays. The second thing is seizures and epilepsy need to be studied and looked at and administered by a team of people who understands that. It is way beyond the expertise of most general practitioners to go past a single medicine and really understand where epilepsy is being managed. That's what the purpose of a institute or a center focused on that is. And so going to have your seizures looked at does require coming to a place that knows a lot about it. There are a number of centers around the United States that have comprehensive epilepsy services. We're one of them. So if you go online, find, if you're in California or the Midwest or New England or the South, find an epilepsy regional center of excellence to go to because that's where you're going to get these solutions at.
Yeah, and how lucky are we to have it right here in West Virginia?
Right
you don't
here.
don't have to travel.
Exactly.
Excellent. Well, thank you so much for being with us. You gave us a lot of good information and a lot of hope. So thank you for that.
It's been a pleasure, Mary.
If you're looking for more information about epilepsy treatment, visit wvumedicine.org/RNI. I also want to tell you, in 2 weeks, we're going to have Tuesday Talks. We'll be talking about back-to-school vaccines. So get ready for that on August 2nd with Dr. Kathy Moffitt. I'm Mary Ravazio Menard, and on behalf of Dr. Konrad and everyone at WVU Medicine, thanks for joining us, and have a great day.